different elements. And one is access to healthy foods. And so what we're doing through this model in 3 communities is screening for diabetes in the food bank setting. So clients who are coming already to pick up a box of food, we're offering them the opportunity to screen for diabetes, talking to them about their risk of diabetes, doing a hemoglobin A1C right there on site so that we can identify people where they are, where they would already be. And then here in our second, our middle circle here on the slide is providing healthy foods. And so we've put together boxes of foods, boxes of non-perishable items like whole grains and low sodium and low sugar items and lean meats, and couple those with fresh produce and dairy, and clients get a box of food that helps them to support the kind of diet that they should be eating to manage their diabetes. And it not only gives them the access to the food that they need, but it also serves as an educational tool to make sure that they understand the kinds of foods that they should be eating. They're introduced to new items and helps them to manage their disease for the long haul. And then here in our fourth circle is the education and making sure that we can reach clients where they are with educational messages that are appropriate for the scenario that they're in. And so once again, we all know that public health efforts can be a challenge sometimes when we can't get clients to come to our educational workshops. But through these partnerships that we've developed, we're actually offering the education, the diet and health education in the food pantry setting where the clients are likely to be with the incentives of the food that's necessary for them. And we're doing all of this in partnership with local healthcare organizations, with clinics, with free clinics, community health centers, community hospitals, to make sure that our efforts are done in connection and that they can be successful. And once we get started with the pilot food banks, we're actually looking to do additional expansion throughout the country. So to share a little bit more about what those partnerships look like and the key elements of them, certainly it's important to leverage existing relationships. We've all tried to build partnerships with brand new organizations, and sometimes that's more challenging. And so looking at the organizations that we have some existing relationships with and building upon those. And throughout this project, we've created several formal relationships with organizations, with the 3 food banks and their healthcare organizations in the community that they have long-standing friendships with. They've been doing some referrals with over the years, and they've been able to really dive deeply into opportunities to think about the clients that they're serving and ways that they can mutually benefit from these programs. Setting clear goals for the roles that each of the organizations are playing. A big piece of what we wanted to accomplish with this was to have a bi-directional referral situation. So the food banks are identifying individuals that don't have a primary care physician, that have been lost to follow-up by the healthcare organizations, and encouraging them to reconnect with the healthcare system, encouraging them to apply for health insurance, engaging them in a discussion about their health, empowering them to reconnect, and making those referrals to healthcare organizations that have some capacity to take new patients. And then on the flip side, the healthcare organizations are talking to their clients about food access issues, and they're making referrals to the food banks for their patients who are struggling. And we know that with those clear goals in mind of what each organization's role is, we're helping to lift all of the patients and putting them, giving them the opportunity to access all of the kinds of services that they need. And really meeting clients where they are. And so talking to clients who are struggling with food access, who are relying on food pantries and food banks across the country, talking to them about the health needs that they have. We know that individuals are worried about the diabetes diagnosis that they're already aware of, or worried about developing diabetes when they live in a family where diabetes runs in their family, or they've had gestational diabetes in the past, and so they're willing to talk about their health in the food pantries when they're already there thank you, Richard, when they're already there to pick up the foods. And so it's an exciting opportunity for us to address the kinds of concerns that they have, giving them education about ways to improve their diet, giving them education about other resources in the community while they're already there in that location. And then a fourth element is really to think about a referral process. Because our clients are at a food bank, it's important to make sure that we don't just give them a flyer, we don't just give them a phone number to call, but that we really follow them through that process to make sure that they get to the physician, to make sure that the physician is able to take them as a new patient. And on the flip side, when a physician identifies an individual who needs food, that they're able to get that in a timely manner. And one of the things that we've really identified is that the language that we speak as community organizations, community-based nonprofit organizations, and healthcare organizations can be very different. The way that we share data, the kinds of information that healthcare organizations need and that food banks collect can be very different. And the processes that we use, sending things by email, sending things by fax, can be a challenge. And so it's really been important for our organizations to work with their healthcare partners and think about how they'll transfer data, using fax lines as opposed to email for privacy purposes, and particularly thinking about all of the considerations for HIPAA that are commonplace for those of us who are in the healthcare organizations, but might not be something that some of your community-based partners are familiar with. So as you're setting up partnership activities, really think about what you're bringing to the table and the kinds of considerations that you need to share with potential partners. So I wanted to share a few of the model food bank healthcare partnerships that we've developed that have been very successful as we are working with this pilot project. And the first, as I mentioned, is screening for diabetes in the food pantry setting. At this point, all of the staff that are, and the volunteers that are doing those screening activities are actually employed by the food banks, because as we set up this pilot project, we wanted to be certain that it was very successful. However, as we look to replicate this model around the country, certainly there are lots of other ways that can come to fruition, and certainly having healthcare organizations provide staff, having organizations provide students and interns to do some of that screening in the food pantry setting could be a wonderful partnership to make sure that more individuals are able to get the healthcare screening activities that could be valuable to them. On the other side of things, screening for food insecurity in the clinical setting. And there are two questions that are part of the U.S. Department of Agriculture's 18-item food insecurity screening that can be used in a clinical setting to really help us identify individuals who are struggling with food access. And so that's been a really great partnership that many of our food banks have worked with their healthcare organizations, with physicians and nurse practitioners and nurses to ask those questions and really empower the patient and physician relationship to go beyond just making providing medical advice and really get to the bottom of the kind of situation in which they're living and understanding the barriers that they have to the ideal self-management, and so that we're not just having clinical advice that's not being heeded, but rather really connecting over the realities that the patient is facing and being able to provide appropriate referrals for food access and for other kinds of resources when those families need that. A third great aspect of the partnership is produce and healthy food distribution, and much of that is taking place in our regular food bank distribution setting, but more and more we're identifying that we can make those distributions take place in a clinic setting. And so when clients come to the clinic, again, it's the idea of meeting the individuals where they are with the kinds of resources that they need. And so as clinics are identifying more and more of their clients or their patients who are struggling with food access, they're able to bring produce and other healthy food to the clinic setting and make those distributions happen there. And then joint self-management education opportunities are really a wonderful way for healthcare organizations to partner with community-based organizations and make sure that we're providing those health education messages in a place where people can access them. So we've started to do more joint education where we bring the food bank's perspective and that expertise on understanding how to help individuals achieve a healthy diet on a budget with the health education expert who can really address other questions that might come up in that setting. One of the things that's been very valuable for our food banks is to create some memorandums of understanding, and it's always nice to have some templates for those, and I'm certainly happy to share those with anyone who's interested, but just to outline some of the pieces that go into that. Because this can be a very valuable way to kick off a partnership and make sure that everything's spelled out and that you're accountable for the things that you'll be doing as a part of a partnership. And so certainly you want to first address the scope of work for both partners or even multiple partners if they all are part of a joint attempt to address food insecurity and health issues. And accountability for the outcomes. Who's responsible for recruiting clients? Who's responsible for various aspects of the partnership? And again, really spelling out that referral process, especially when we're providing information from one organization to the next, and making sure that we have a way to track the numbers of patients who are referred and track the data that we're all collectively looking to collect for the third element of this important partnership. One of the things that a couple of our food banks have really highlighted, that as we identify more and more individuals who have these kinds of needs, sometimes we actually have to put a cap on monthly numbers, or you may have to think about sort of a minimum number of individuals that you'd like to refer every month. So really thinking through the capacity of different partners to service more individuals, to provide more health education, to do more screening. How many referrals can you take in a month and add that to your existing patient load in a clinic, or how many new patients can you take on? And then finally, partnership funding is always a struggle, and it's very important to include that information in a memorandum of understanding so that if you're seeking joint funding, that it's clear how that will be designated, and if different partners are bringing their own funding to the table, that's clear from the outset as well. So those are some of the things that we've learned, and I just really want to highlight that as we think about the three-element model and really engaging and empowering the clients that we're serving, that we think beyond their healthcare needs and really about some of the additional challenges that lead to their health, and certainly food access is one of the big ones as we consider ways to address the diabetes epidemic. So thank you very much, and I look forward to the rest of the presentations.
Kim, thank you very much for really an exciting and interesting presentation, and it looks like I'm going to have the opportunity to ask you a few questions later on, and then our audience out there is also going to have the opportunity to send in questions for you. So don't go away. But our next speaker is Diana Erlaub. Diana Erlaub is a program manager with Peers for Progress, a program of the American Academy of Family Physicians Foundation. Ms. Erlaub has over 10 years of experience managing public health programs. In her work with Peers for Progress, she leads the implementation and evaluation of the diabetes management through peer support and community outreach from the Patient-Centered Medical Home program, which is part of the Bristol-Myers Squibb Foundation's Together on Diabetes initiative. Ms. Erlaub works extensively with program partners Alivio Medical Center, National Council of La Raza, and Transformed to develop and implement the program's objectives. Ms. Erlaub.
Hi, thank you. I hope everyone can hear me. I'm delighted to be part of the panel today on community engagement. So I'm going to talk about steps involved in developing a peer support program. I'm just going to try to go to the next slide. Thank you. If you could go one back. Oh, is it right here?
You look on your screen.
Okay, okay, I think I've lost the slide, but I want to mention that we have a guide for developing peer development and management of peer support programs. It's on our website, and it's at peersforprogress.org under implement and then start a program. And I mention that because my overview today is going to be very brief in how to develop a peer support program. I'm going to focus on some key factors to consider when developing a peer support program, such as these listed here.
Human.
For a more comprehensive overview.
That picture, that last image of you was paused. I see. So that.
Okay. Sorry, I'm hearing some other things on it. I just wasn't sure. Should I keep going? Okay.
Yes, continue.
Sorry about that. I just heard some noise. Just wanted to mention, for a more comprehensive overview, please refer to the program development guide that I just mentioned. And we also have other program resources available on our website, and you can contact us by email, which I will provide again at the end of my talk. Okay. When beginning to plan a peer support program, you want to keep in mind the interrelationships of the peer supporters, your target community, and the organization itself to have an integrated perspective. And now I'm going to talk about planning a peer support program. It's important to consider the modes of peer support, organizational readiness, having clearly defined roles and responsibilities for your peer supporters as well as other members of the clinical team if the peer support is going to be happening in a clinical setting, planning for recruitment and how that will happen, and selection of peer supporters, as well as documentation, monitoring, and evaluation, as well as sustainability of the program. And as far as modes of peer supporters can be part of a community-based organization that is linked to clinical providers, for example, or they can be based in a clinic setting with strong linkages to the community. Peer support can be delivered on one-on-one, whether it's telephone or face-to-face, in which an individual, a trained peer supporter, offers assistance, coaching, and just being there to the clients that they serve. Peer support can also be offered in groups. For example, peer supporters can facilitate education classes, support groups. They can be part of a group medical visits, and linked to the medical team. Some examples of work peer supporters can do in clinical settings include performing outreach, patient engagement, self-management education from a patient-centered medical home, for example. They can be part of the clinical team, which could be including them in activities such as huddles, as well as pre-visit planning. And also, they can work as extenders of support care and clinical services under the supervision often of care managers and nurses. In terms of organizational readiness, this is another factor to consider when planning a peer support program. It's important to secure buy-in from your stakeholders. Administrative backing of the program is essential. And if it's being done in a clinical setting, for example, physician and clinical staff buy-in are critical. You want to establish buy-in both within and outside the organization. Develop program goals and objectives with your stakeholders. You can even involve them in developing the protocol and delivering training to the peer supporters. For example, in our program with Alivio Medical Center in Chicago, which is part of our Together on Diabetes initiative grant, we're integrating peer support with primary care patient-centered medical home, and we involved the diabetes physicians in developing the peer support protocol, and we also involve the certified diabetes educator in training peer supporters to deliver, training them to learn diabetes self-management education as well as to deliver it to the patient. And it's also very important, and I can't stress this enough, is to identify and assign a dedicated staff member for coordination of the entire peer support program. One of the main things that helps secure and maintain levels of buy-in and success are having clearly defined roles and responsibilities for the peer supporters, as well as other team members as to how they will work with peer support. This helps people understand the unique role of peer support as extenders of education and support. It reduces concerns that peer supporters will go beyond their scope of work. Peers for Progress has defined peer support according to 4 key functions. These include assistance in daily management, social and emotional support, linkage to clinical care and community resources, and ongoing support. And this is a great place to start when developing peer support roles and responsibilities. You'll need to plan for recruitment of peer supporters. You'll want to identify your prerequisites of selection, knowledge level, and skills that you'll be looking for, as well as other community and cultural characteristics that the peer supporters will need to have. And you'll want to employ a systematic screening process of potential peer supporters. And some places to look for peer supporters can include social networks, your collaborating or clinical groups or other organizations, as well as individuals who might be filling similar roles in other programs. And more about recruiting peer supporters. When recruiting and selecting your peer supporters, you'll want to look for individuals who have time available. This is really key. You'll want to look for people who like to talk to others and are happy to find out about people's lives, their children, and their interests. And you'll want people who are broad-minded and do not see diabetes or people's health problems as simple. There are no easy answers, and if someone thinks they have a magic bullet or all the answers, they may not make a good peer supporter. You'll want to look for people who are able to learn and teach basic disease management or health promotion behaviors, and also look for those who will use backup from professionals and others in the program so that they're willing to use the resources that you give them for support in the program. And in training peer supporters, the goal is to be able to help others implement their management plan. They don't need to have the skills of a nurse or a dietitian, so the training is really to the knowledge of a patient who understands their diabetes well. And we recommend teaching skills for really simple counseling skills such as active listening or very basic motivational interviewing skills. And as far as length of training, 20 hours is common, although we have seen programs that range from 3 to 4 hours up to about 80 hours. And this just depends on the complexity or the nature of the program. We also recommend keeping training simple, train to the protocol. Peer supporters should know what their responsibilities are, how do they introduce themselves and interact with their clients. They'll need good problem-solving skills so that they can help people identify a problem and find ways to come up with solutions and select a solution, try it, evaluate it, rehearse it, things like that. And also problem-specific issues, such as for diabetes, simple blood sugar monitoring and things like that. And in implementing a program, there are key questions that you can consider related to delivery of peer support, such as how will peer supporters be paired with their participants? Will patients get to choose their peer supporter, or will one be assigned to them? Will there be matching on age or gender or other factors? And how many participants will each peer supporter manage? Also, how will the peer supporters contact their participants? Face-to-face, telephone, groups? How will those things happen? And how often will the peer supporters contact each participant? For example, in our program with the Alivio Medical Center, our high-need group patients are contacted biweekly for 3 months at the beginning of the program, then monthly until their peer supporter felt that they could manage for themselves, at which time they were then moved to a quarterly contact. And other programs might be less prescriptive and ask that there be at least 6 contacts over 12 months, and then the timing and frequency are determined and left up to the peer supporter and their clients. Also think about, will peer supporters follow a set curriculum or with the patients, or will the content be flexible? In managing peer support programs, You'll want to make sure you have a clearly identified manager of the program who has time allowed for this responsibility. This is really important to have someone to be able to wrap their arms around the program and make sure that it's being implemented the way that you need it to be. You'll need a backup plan for the peer supporters. How should they handle the questions that they have and issues that come up when they're interacting with clients that they may not be able to address. They'll need a 24-hour backup person like a nurse or a primary care specialist, someone they can go to get quick answers. They'll need to be able to give prompt responses to patients when they have problems. This will help them build their trust and have a good relationship with their patients. And ongoing support for the peer supporters. Often we'll have, weekly meetings for peer supporters to be able to share with each other things that they're doing that help and also help each other problem solve. And that also they can provide each other emotional support for difficulties when those are encountered. Monitoring and supervision as reflecting the importance of their work, not a tone of mistrust or not surveillance. So that's very important as well. And just last but not least, there's some key, I'd like to just go over some key success factors for peer support programs. The first thing to remember is just to keep it simple and remember that peer support is meant to be from people like me. Also avoid too many details in training. As I mentioned earlier, the key is knowing, listening, and being available. And this visual shows a photo from a research study in like 1960 or so, showing that a baby monkey, even though the source of food is being provided by the wire mama, the baby preferred to spend most of its time with the comfortable, warm terry cloth mother. And this demonstrates that primates, including Homo sapiens, will seek out and choose warmth and comfort if it's available to them. And last but not least, a key success factor is ongoing support and information for the peer supporters. Like I said earlier, having that reliable backup system in place is critical. And this could be from a program manager or a nurse if the program is in a clinical setting. Thank you. Please. If you have any questions, my email address is here, and you can also visit our website for more resources like I mentioned and follow us on Twitter. Thanks.
Thank you. Good morning, everyone. It's a pleasure to be here with you. I just want to, can you all hear me? Okay, great. Can you, okay, perfect. Great, thank you. So it's a pleasure to share our experience with you today. Again, my name is Sandra Leal, and I'm the Director of Pharmacy Services, Clinical Pharmacy Services at El Rio Health Center. And so one of the things I wanted to talk about today is our work with using pharmacists as part of our innovative model to deliver diabetes care at the health center that we serve. And then also our community involvement. We've really used the clinical pharmacist and the pharmacist as a profession and as an extender to the work and the team that we have at El Rio. So for about 13 years now, we really utilize a pharmacist in a setting that's very different from what you typically think of for the pharmacist. It's really taking the pharmacist and integrating them into a treatment team with the patient and actually having appointments and group visits with patients, but really having the pharmacist serve as one of the additional providers that really helps get the person to goal. And so when you think of diabetes or any of the other chronic conditions that are very medication heavy, you could see a lot of the possibilities of utilizing this sometimes very underutilized resource. We spend quite a bit of time with the patient making sure that they understand their medication regimen, and in I want to say more than 47 states now, pharmacists have the ability to have prescriptive authority. So in collaboration with providers, pharmacists are able to make medication adjustments, or they're able to make initiation of medication, they are able to stop medication. So our emphasis is really on a comprehensive review of medications and then working with patients and working within the community environment to find out what the barriers are for patients to be adherent. So we end up finding a lot of issues related to affordability of medications, side effects of medications, being able to have the adherence because of transportation issues associated with the medication use process. And so we've started to use this resource as an ability for us to be able to have that extension and help patients do what they do every day. So when a patient leaves a visit from the clinic, what do they have to do every day? They have to take their medications on a daily basis and hope that they're having positive outcomes with that. So we've really extended this collaborative. I'm the national chair currently for the Patient Safety Collaborative, and what this is a national collaborative that was initially funded by HRSA to be able to replicate this model of using clinical pharmacists and safety node organizations and actually working with community partners to extend that reach away from the clinic walls. So the model has been really successful. We've had over 430 teams across the country that have this type of model that's been replicated. And so we've developed different community partnerships with colleges of pharmacy, with community pharmacies, and really it's to build a bridge and to build that network out into the community to support patients once they leave the clinic. So one of the most recent partnerships that's been really exciting as part of this collaborative is our work with the quality improvement organizations in each of the states. So currently each state has a quality improvement organization, and so there was a directive to be able to have these patient safety teams collaborate with a quality improvement organization to build a bridge into the community and have significant outcome improvement in health outcomes, so health outcomes related to diabetes, but then also in decreasing and preventing adverse drug events. So we've been really targeting collecting data to show the impact of our interventions and what we're able to do in order to reduce A1Cs, reduce adverse drug events, and then over time see the health benefits to the patients. The nice thing about working with our quality improvement organizations is they're actually looking at Medicare's claims data, so we're able to see if we're actually having an impact on the costs associated with care for those patients with diabetes. So that QIO partnership is going to continue. We're actually in the 6th cycle of the Patient Safety Collaborative, and it's about ready to become a kind of like a public-private partnership. So there's still time and room to join this collaborative. But what's exciting is that the quality improvement organizations in August will be starting a new scope of work. And what that means is that they're actually going to be targeting a specific goals for that QIO scope of work, which lasts 5 years. And this is related to diabetes. Their scope of work for the next 5 years will relate to community enhancement, community involvement, and community outreach in patients with diabetes. So we work and we will continue to work to develop these partnerships. A couple of the programs that we're currently developing that are kind of interesting are our outreach of vaccinations, for example. One of the things that we did is we partnered with community promotoras, so community outreach workers, lay workers, that will go out into communities and recruit patients from their own community and bring them into pharmacies to get their vaccinations. So we're targeting vaccines that are sometimes not offered in a lot of the underserved communities to the same levels as other communities, like pneumococcal vaccine, influenza vaccine, but with that very interesting partnership with community outreach workers and pharmacies, we're trying to enhance access to care and trying to get people connected to care without them having to come to see us. And so that's really exciting. Another unique partnership we've developed is partnerships with ophthalmologists. Like here at El Rio, we developed a partnership with an ophthalmologist in the community where they actually donated an eye screening camera for us to be able to do the diabetes retinopathy screenings for patients that were not getting in to see the ophthalmologist. So a lot of times they had that referral in the system, everything was set, but for whatever reason the patients were not able to get there. And when we identified what those issues were, they were simple things like transportation issue, it was language barrier issues making that appointment, it was child care issues, or affordability of the copay associated with that issue. So by being able to have the ophthalmologist donate that camera, we increased our screenings by almost 600% because we placed that camera in a place that people were already going. And we also placed that camera in a place where we had bilingual people who were taking the pictures for the ophthalmologist. And so just having those creative partnerships and thinking outside the box and looking at our resources in the community, we were really able to identify some of those barriers and then come up with very concrete solutions to figure out how to overcome those barriers. So really my message to you is think about partners out in the community that would be very helpful. Think about pharmacists especially. They're the most accessible providers. You don't need an appointment to go and see them. And a lot of times they can help the patient navigate either resources or information or, you know, be an advocate for the patient when they have other providers there. So I always just really hope that you can think about that. And we're really working very diligently with the Patient Safety Collaborative to continue to expand these partnerships and these teams as we move forward with a quality improvement organization in their next scope of work. So that's what I have. Thank you.
Okay, now I'm back on. Sorry about that, Dr. Blumenthal. I'm back on. And in my rush to get my audio back on, can you just repeat the question that you want me to address again? Great, absolutely. Well, I think that the partnerships that the food banks have had with their healthcare organizations locally have been really, really exciting and somewhat unique as far as some of the community partnerships have gone, because it's really new territory for us as hunger relief organizations to be talking this in depth about the health status of our clients and the kinds of foods that they need for good health, and even doing these health screenings at the food bank sites. So all of the partnerships, while I mentioned in the beginning, really thinking about leveraging some existing relationships, while there had been a lot of high-level referrals happening in the past, sort of just these are the things that you need to know about where your local health organizations are, and here's brochures and things. The way that they approached these relationships was very, very different in that they were really talking about, starting by thinking about the needs of the clients, what's the geographic reach of the clients, making sure that they were not only finding organizations that were a good fit for the kind of work that they were doing, but even the food bank was has started to create new food distribution sites to make sure that they were reaching the needs of the patients of the community health centers. And so, really sitting down with those organizations and saying, here are the things that we're interested in, here are the things that we have to offer, what are the needs of your clients, where are your clients, how can we work together towards this common goal? Which is really exciting. And then I mentioned a lot about the, creating formal relationships and the memorandums of understanding, because it is such a different kinds of organizations coming together. That was a really key element to make these successful. Another one of the key elements, I think, is finding those program champions at multiple levels in the organizations. And so on one hand, making sure that you have champions of the program at the leadership level, and so that the medical directors and the administrative directors of the clinics are really on board with changing practices in terms of doing screening of patients for food insecurity, and that the food bank is really on board with spending money on different kinds of food and doing these health screenings, that their agency partners where they might be doing the health screenings are excited about that, because it really is a different way of doing business. And then certainly getting champions on the ground in each of those organizations. And so while the medical director might be excited about making some changes and addressing food access issues for his patients in a clinic, it's only if the clinic manager or the registration people or the clinicians themselves are willing. And so really finding some of those clinic community champions in the clinics and certainly in the agencies as well, where those things are happening, where the referrals are taking place, the people who are getting the faxes, the day-to-day operational people. That's been really, really important. I will say at the beginning of this, thanks to the generous support from the Bristol-Myers Squibb Foundation, we did have a little bit of money, and in a few places there was a little bit of money offered between the partners to make sure that we were offsetting some of the new costs that were being incurred. And we quickly found that that wasn't always necessary, that when these partnerships were successful and the various partners saw the value to the work that they're already doing,
I'd like to
that
thank
wasn't
all of our
necessary.
presenters for
so that's been an exciting,
again,
finding for us. And I think because it's a pilot project, we haven't really had any total failures. One of the things that we do see in nonprofits and in public health and community health is a lot of turnover. And so that's been, again, when you find a community champion, a champion who really gets excited about this partnership and the day-to-day relevance to their work, but then they leave. That's been one of the challenges, is just making sure that there's adequate buy-in amongst all of those partners to say, yes, even though we're a clinic, we're a healthcare organization, we really value the need for food access conversations for this low-income population that we serve. So even though this person has left, our organization is still committed to this partnership.
I'm not sure if Ms. Prendergast can hear me.
Can you repeat the questions one more time?
Oh, okay. Sure. So everybody's been talking about partnerships, and I'm interested in in comparing and contrasting the way the different presenters, the different organizations go about creating partnerships and sustaining partnerships. So I'd just like to hear a bit more about how you identify partners, how you generate a partnership, how you make it successful and sustainable.
Yeah,
and whether
the level I work is
you've had any
not
failures in
at the
partnerships
clinic
and how you get out
level.
of one if you need to.
So our program is being implemented in the community at a federally qualified health center, and they have many linkages and partnerships with the community there. At the program level where I work, we have our partnership with the FQHC, with our other program partners, TransferMed, who is helping Alivio become a patient-centered medical home. We have NCLR, the National Council of La Raza, helping us with dissemination and development and dissemination of program resources. And we also have American Academy of Family Physicians Foundations, with whom we work closely, and then our funders, Bristol Myers Squibb Foundation. So for us, this has been a collaboration around getting these demonstration projects started for the diabetes, for the Together on Diabetes initiative, and seeing where we can take this from here at a national level. I hope that answers the question. Yes.
Yeah, yes, absolutely. Sure. When we started our program about 13 years ago, we started off with a grant, and many programs start off with grant, but I think one of the key things that we quickly identified was the importance of us being able to have a sustainable program. Since we started, it was one position integrating the pharmacists, and really we've expanded that. Now we have 8 clinical pharmacists at 8 different sites, and we've started to develop very formal relationships with the College of Pharmacy to have co-funded positions between the college, which is nice. I think that's one of the key ways and key strategies right now to get partnerships with colleges of pharmacies, because they're looking for training sites for their students, and so they're also looking for placement of faculty in practice settings like safety net organizations, and then in community pharmacies. But we really looked at strategy and documenting our impact. I think that for me has been the single most important reason why we've been able to expand the work that we have. We've been able to integrate, we've been able to document our impact, and we've been able to show that we can replicate this model and we can replicate it effectively. And as healthcare is changing, as healthcare reform has happened, we've noticed that a lot of the reimbursement around the type of work that we're doing is really based on outcomes. So our ability to show very concrete publishable outcomes on A1C reductions, on our ability to reduce adverse drug effects, is really resonating a lot with payers right now. And I think for us, that's been a very key ingredient in us being able to develop partnerships that are sustainable and that are able to be replicated and expanded to other sites. And so we have had a lot of success, and I appreciate you asking how do we get out of some of these relationships, because that is something that's very, very real. We get out of these relationships when we find that we're not having impact. Sometimes we start a program, and if we're not able to document an improvement, there's so many other areas that we can target that we simply try what we call the PDSA cycles. I'm sure a lot of you are familiar with those. We plan, do, study, act, and we study what we're doing, we measure it, and if we're having impact that's of value to the third-party players, to our administrators, to our organizational goals, then we're able to continue to develop those services. So if not, then we just simply stop, and then we redirect our investment into something else that will be critical and that will work. So we really think that measuring data is very critical, and for us, I think that's been the key ingredient, like I said, to be able to spread these services in a way that is actually not just dependent on grants. And I've had that struggle with certain interventions that we've had where we had a grant, it didn't work so we had to move on. But we've had success in other areas that have allowed us to continue to grow and allowed us to have those expansions and additional services that are actually very important and very measurable for successful outcomes.
Very good, thanks. Let me let our other two presenters take a crack at that set of questions. Ms. Erlaub? Sure, this is about partnership formation and sustainability. All of our presenters have talked about the partnerships that they have created and through which their program is conducted. And the question is about how you identify partners, how you create a partnership, how you make it sustainable, and how you make it successful. Some of the nitty-gritty about partnership development, and in case a partnership goes wrong, how do you get out of it? So could you tell us a little about your experiences in that regard?
Thanks so much, Dr. Blumenthal. And to our presenters, you ladies were awesome. We do have a few questions from the audience. I'll get some of them you guys have already addressed through chat, so I'll get to the new ones first. And then if we have a chance, I'll go back and have you respond to the others just so we can have it on the recording of the webinar. So there was a question from Marina. She asked about the Memorandum of Understanding. So where can the criteria be found? Is it available online anywhere? And I'm assuming it's just an MOU with any kind of partnership that you're looking to form.
Yes, so I'm the one that talked about that. So I'm happy to share some of the MOUs that our food banks have developed with their partners. And I don't know if, Sabrina, if the slides from this will be available afterwards, but Marina, I'm happy to, share sort of those bullet points, which are kind of the best practices that our team has come up with as being pieces of an MOU that are really important. I think the most important part of an MOU is not the exact format that it takes, but really thinking through what's the role each organization is going to play. What are the accountability pieces that you want to put into place to be sure that the partnership goes as you expect it to? And what are the outcomes that you're seeking to achieve with your partnership? And how will you know if you've met those? And so if you really walk through those, and it's less about a scary document and more about kind of the conversation that you've had about what you're looking to achieve, and then just putting that on paper, again, so that should people change, should staff change, should leadership change, that you have it all in writing. So there shouldn't ever be any surprises in that MOU, but it's really just sort of putting all of that, the plan that you've agreed to for your partnership on paper. But certainly I'm happy to share that, and I don't know, Sabrina, you can let us know if there are good ways to share information, and maybe probably what she's going to tell me is that the best place is for me to put those on our Diabetes Health Equity section on the diabeteshealthequity.org site.
You must be a mind reader.
There's our advertisement for that great website that Morehouse has put together for us.
Yes, and part of our idea is to be an online portal and a resource center so that other awardees can share amongst each other, people out in the community who are looking to make a difference in this space of health equity for diabetes outcomes can come and find it. So we will, Feeding America has a story, a best practice story on the site. We do have a resource section that is just for community. And so, Kim, anything you'd like to share with permission, we'd be more than happy to put it up there. And to answer your other question, yes, this presentation
will be available on demand for people to go back and listen, and then we'll put the slides up as well. So I think I answered all of that. There was another question, and I think this is to anyone. How is the I'm assuming education component incorporated into the program, one-on-one training, group training, or both? And whomever is best positioned to answer may answer the question.
I can start with some of the different models that we have. We definitely have the face-to-face trainings and education, but we also have group visits, and we've done a variety of different types of group classes. We have the traditional classes, but we also have the diabetes conversation maps, which are more facilitated groups where we get people to really talk about their own experiences, and then we just serve more as just facilitators to make sure the information that's being shared is correct. We've gone out into the community, and what some of our most successful classes that have been attended have been the classes that we have in the libraries that are close to the different neighborhoods. We've had classes in the park where we have people come out to a less, I guess, a less intimidating environment. So we really like to work with our health promoters, our promotoras, and they really help fill up classes for us. But we really try to also engage people in letting us know what they want to hear about versus what we want to talk about. And that's been another successful strategy. You know, sometimes we'll just ask people, what do you guys want to talk on? And they'll say, oh, we want to hear about vitamins and supplements. And so I prepare myself to be able to speak to that, but they've really selected the topic, and half of it is directed at a specific topic, and then the other half is more, you know, questions and answers. What are they hearing from their neighbors? And so those have been actually more educational for me, because I see what's going out in the community, what people are talking about, what the trends are, and we can really bring it back to the clinic and then use it as information for our other participants here, or other patients here.
Creating the partnership, but for the physician.
Right, and if I can just jump in and say, as a dietitian and a food bank person, I'm always going to say that, you know, we have to think about the food as well. And so a big piece of what we really consider in the education is coupling all of the diabetes education with food. And so we know that from the population that we're looking to serve, that having, you know, making sure that we tie education to a food distribution has been really successful, and making sure that people come. They're more incented to come if they know they're both getting great information about how to manage their health, but also the box of food, the bag of produce to go along with that. And so that's been a really nice way to incent people to come, but also to talk about, especially when we're talking about healthy eating, talking about the kinds of things that you can really make this week, because these are the ingredients that you have. And likewise, many of our food banks in the Redwood Empire Food Bank in Santa Rosa is one of the pilot projects in this, is doing classes in their kitchen. So again, it's hands-on information about how to make these foods, how to eat healthy, which is another way to really motivate and engage clients about embracing managing their diabetes, as opposed to just, you know, talking about the things, but getting them really engaged in the process.
Follow-up question to that. For if there's someone out there listening and they don't currently have an education program going on, what would be some recommendations of just how to start? What are some baby steps? Is it once a week, once a month? Do you get staff to donate food and come in? Do you leverage a community partnership to try to get someone to come and do a food demonstration? What would be a baby step to take?
I would say, you know, there's so many different things. You've mentioned a few of them. Definitely partnerships in the community are very helpful. So many people are in the community are often providing similar services. So we look to see who our community partners are and try not to really reinvent what's already happening, but maybe enhance what's happening, or offer a different language, or you know, work with local resources that are just outside the box. So for example, the food bank is a great way to start. Here in Tucson, for example, the food bank offers some gardening classes. They offer a lot of different resources that a lot of our clinicians and the patients in the community, or people in the community, don't even realize are available. So just kind of getting an inventory of seeing what's out there already is a really good start, and then you can always start seeing what the gaps are and really try to fill in those gaps, or try to, you know, maybe collaborate with somebody. Look for volunteers. I always turn to our College of Pharmacy, our College of Nursing, our College of Public Health. They're always a wealth of resources from very excited students that need projects. You know, so if you can engage them and have them sort of be your workforce, it doesn't really take away from your resources. It really just adds to the resources that are available for you. So I always start with those couple of things, just inventory and then look at what's already available out there and what resources you can leverage.
I totally agree. Oh yeah, I just wanted to say really quick, the other piece, you know, we always start with, as we talk about sort of baby steps and first steps, that it all starts with a community assessment, and very similar to what Dr. Leal just said. I think the other thing is that much of what we did in our education was kicking off with, you know, the one-on-one education and face-to-face conversations with the clients to get a sense of what they wanted. How often will you come? Will you come to a 6-week class series? They might say they will, but then they show us that they're not able to accomplish that in their lives, and so we've created different kinds of approaches to one-time, you know, maybe it's just a one-time event before you call it a once a week or a once a month, to see who comes and how engaged they are and what it is that they want. And so really getting a sense from the individuals themselves, what are you willing to commit to, what is it that you feel that you need, and starting with that to meet their needs, and then kind of going on from there from our healthcare practitioner hat to provide them what we think they should have.
A question for you, Diana, and I've already thought of another question too. So for people who are not currently doing, you know, peer support, is there training at Peers for Progress that someone can come to, or are there other peer organizations in various states that would train our group how to do it, or do we just come to your website and download a manual or watch a video? How does that work?
Excuse me, most people do contact us through our website, and we usually work with people on a one-on-one basis to find out what exactly the type of program they're interested in implementing, and we can help them design a training, but we usually encourage programs to do their own trainings and use their own resources and develop those internally. But we definitely can help provide the technical assistance and resources that programs and organizations would need to start a peer support program.
And since we're talking about the 3-element model and wanting to just keep in the forefronts of our mind of keeping it all connected, are there any easy ways to do tracking or to handle the data that comes from these classes? Are there established surveys that measure knowledge, or do you recommend that everybody just creates their own things they would like to measure? And anyone could answer, because how do you measure the effectiveness of having these groups?
So I wouldn't recommend just creating new survey tools, because certainly it's always better to use some validated tools which help you to compare the results that you're getting with existing data. There's lots of great tools in, surveys in the literature, and I'm happy to share ours. So what we're doing with the Feeding America project is a pre and post survey, and some of the questions that we're looking at are fruit and vegetable intake, the diabetes distress scale, a diabetes self-efficacy scale, medication adherence, depression questions, certainly the food insecurity questions, just to name a few. And those, at the end of our project, we can probably post the whole thing on there, and along with as we post some of our results. And I have a table that outlines all of the validated survey instruments that we've used to put into our pre and post survey, so I'd be happy to share that one as well. So Sabrina, I think I have a big list of things that I'm promising here that I'll get you for the diabeteshealthequity.org site.
I see our time is quickly winding up. I would like to, not sure if there are any other questions from the audience, but I will just want to read a few announcements as we are coming to a close. I would like to say thank you so much to our presenters and to Dr. Blumenthal, our moderator. Thank you so much for the work that you're doing and the difference that you are making. And thank you for taking your time today to come and share with our audience. This is day number 1. We are so excited that there are more and more and more things to come. So to our audience, thanks. Remember that during the next 3 days, we would love to connect with you. Join us tomorrow night at 7 p.m. Eastern Standard Time for our Day 2 event, which will be a discussion with representatives from South Central Foundation in Anchorage, Alaska, and the Camden Coalition in Camden, New Jersey. Two very different cities that have successfully integrated clinic, community, and data outcomes in a rapid cycle of quality improvement. We'd also like to let you know that you can tweet us, and hopefully I get this right, at P4DHE, that's P4DHE, and use the number sign hashtag PDHE. You can also like us on Facebook, and of course you can visit us at www.diabeteshealthequity.org. On our website, you can post a comment on the forum. You can read a best practice story. You can download a tool or template. Or if you have questions, comments, you know of a best practice story that would be great for us to capture. You have a diabetes health equity champion you'd like to recommend us to get to know, then please just email us at info@diabeteshealthequity.org. So again, thank you to our panelists. And just as a reminder, this project is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and the Bristol Myers Squibb Foundation Together on Diabetes Initiative. We look forward to seeing you all tomorrow night at 7 p.m. Eastern Standard Time. Have a great afternoon.
Thank you.
Thank you.
And for those who are still on, don't forget to complete the survey. The link is in the chat box to your right. Thank you.